Historically designated as the forgotten valve, the tricuspid valve has undergone a major clinical paradigm shift. Driven by advances in multimodality imaging and transcatheter edge-to-edge repair, contemporary classification schemas have evolved beyond a simple binary view of tricuspid valve disease. Understanding its etiopathogenesis requires separating primary or organic disease from secondary functional phenotypes, the latter of which comprises the vast majority of clinical cases. Secondary TR accounts for over 90% of clinically significant cases in developed nations. In these phenotypes, the valve leaflets and chordae are anatomically normal. Regurgitation is entirely driven by altered right atrial or right ventricular geometry and shifting hemodynamic loading conditions. Contemporary guidelines and consensus classifications distinguish between two distinct functional phenotypes based on the primary anatomic driver of remodeling. Atrial secondary TR. Primary driver is right atrial enlargement and contractile dysfunction, typically precipitated by long-standing atrial fibrillation or heart failure with preserved ejection fraction. Pathomechanism. RA dilation leads to direct expansion and distortion of the tricuspid annulus. Because the leaflets fail to grow proportionately to match the expanding annular area, an imbalance between the leaflet tissue area and the annular orifice develops, resulting in malcoaptation. Geometric features. Minimal or absent leaflet tethering. RV geometry, volume and longitudinal function remain largely preserved in the early to mid stages of the disease. Ventricular secondary TR. Primary driver RV dilatation, spherical remodeling and systolic dysfunction. This is most commonly secondary to left-sided valvular heart disease like chronic mitral or aortic valve disease, left ventricular failure or precapillary pulmonary hypertension. Pathomechanism. As the RV remodels and dilates, the papillary muscles are displaced apically and laterally. This displacement exerts excessive tension on the chordae tendineae, causing severe systolic leaflet tethering, apical tenting, and preventing normal coaptation. Geometric features. Marked RV structural distortion, pronounced leaflet tenting, and variable degrees of annular dilatation. Primary tricuspid valve disease stems from intrinsic structural, mechanical, or infectious damage to the leaflets, chordae tendineae, or papillary muscles themselves. It represents less than 10% of TR cases, but is a leading cause of tricuspid stenosis. Infective endocarditis, a classic primary etiology, frequently seen in the context of intravenous drug use or increasingly associated with cardiac implantable electronic devices like pacemakers or ICD leads. Leads can cause direct physical perforation, laceration, or mechanical restriction and fibrosis of the leaflets. Rheumatic heart disease. Though declining in Western nations, RHD remains a major global cause of organic tricuspid valve disease. It typically presents as a diffuse fibrous thickening, fusion of the commissures, and shortening of the chordae, often resulting in a mixed phenotype of tricuspid stenosis and regurgitation. Congenital anomalies. The most notable is Epstein's anomaly, characterized by the apical displacement of the septal and posterior leaflets into the right ventricle, effectively atrializing a portion of the right ventricle. Other rare congenital etiologies include tricuspid atresia and congenital cleft leaflets. Carcinoid heart disease. a unique paraneoplastic manifestation of neuroendocrine tumors metastatic to liver. Vasoactive substances such as serotonin cause the deposition of dense, pearly white fibrous plaques on the endocardial surfaces of the walls. This anchors the leaflets in a semi-open position, causing severe fixed TR and variable tricuspid stenosis. Iatrogenic and trauma. Severe structural TR can result from direct chest wall trauma, example deceleration injuries leading to a caudal rupture, or endomyocardial biopsy-induced damage during surveillance of cardiac transplants. To understand why secondary TR progresses rapidly, the unique asymmetric architecture of the tricuspid annulus must be highlighted. Unlike the fibrous symmetrical mitral annulus, the tricuspid annulus is a highly dynamic, compliant, 3D saddle-shaped structure. When volume or pressure overload triggers annular dilatation, the remodeling is highly asymmetric. Septal sparing. The septal portion of the annulus is anchored to the fibrous skeleton of the heart and remains relatively resistant to dilatation. Free wall expansion. Dilatation occurs windows outwards, predominantly along the free wall attachments of the anterior and posterior leaflets. Planar flattening. As the annulus expands, it loses its normal 3D saddle-shaped configuration, transitioning into a flattened circular planar geometry. This structural distortion severely undermines coaptation and initiates a vicious cycle. That is, TR causes further right-sided volume overload, accelerating annular dilation and worsening the regurgitation. The etiopathogenic distinction between these phenotypes heavily dictates timing and selection for intervention. The 2025 ESC EACTS guidelines on valvular heart disease introduced a major paradigm shift by upgrading transcatheter tricuspid valve therapies such as transcatheter edge-to-edge repair or replacement to a mainstream recommendation Class 2A for symptomatic severe secondary TR. Crucially, this intervention is highly contingent on early phenotypic identification before the patient reaches an irreversible hemodynamic point of no return defined by severe irreversible RV dysfunction or fixed precapillary pulmonary hypertension.